All right. Hi, everyone. Welcome. This is our third and final set of PFRH Master's Essay presentations. So we have a set of 4 great presentations for you today. Thanks so much for joining. I'll say this at the end as well, but welcome to family, friends, and advisors and essay readers of our students. Thanks so much for all of the support that you have given our students this year and beyond. We will have 10 minutes for each presentations and then about 5 minutes of Q&A following each presentation. And I do want to note that if you are looking for we have 2 simultaneous sessions happening right now. So if you're looking for Kayla, Malik, Chamini, Olivia, or Elena, they're in a different session. And I'm putting that Zoom link in right now. So without anything further, I will go ahead and introduce our first presenter. Flo Awde is going to, sorry, Flo, I'm missing where you are coming from, where you were at before. So sorry. Okay, so Flo has a Bachelor of Arts in Interdisciplinary and Psychology from St. Thomas University. Flo, I'll pass it over to you.
Thank you so much, Sally. And I'm just going to go ahead and share my screen. Perfect. And if someone could just verify they can see everything okay, that would be wonderful.
Yep, looks perfect.
Amazing. So thank you so much, everyone, for joining today. I'm going to be presenting my master's thesis research study entitled The New Playbook for Health Equity, a scoping review of barriers, facilitators, and recommendations for youth sports participation. So I just want to start off on a personal note and talking about the formative role that sports has played in my own life. As the true Canadian fashion, I started skating when I was 2.5 years old, grew up playing several sports, and I ended up falling in love with hockey, and it really shaped my view of how sports can really connect you into the community. Educational attainment wise, I funded my education through hockey and really tied myself into the communities of my schools through sports and the power of sports, and it really built up my confidence and it sparked my passion to join public health as well. And it's important to note that these benefits I just mentioned, they're not just isolated to the experience I had, but to many youth that participate in sports. So in the physical domain, sports has been proven to boost activity, fitness levels, lower disease risk, increase quality of life. Socially, it builds connection, sense of community, communication skills, leadership, and life skills. Psychologically, it does lower the rate of anxiety, depression, and substance use, suicide, and stress. And academically, it is linked to higher educational attainment and performance outcomes, as well as better adult health outcomes and employment opportunities. And it's unfortunate that we do need to note that although we do have approximately 60 million children that are registered in the United States to play youth sports, this participation opportunity is not equitable, and therefore these opportunities to gain these benefits of sports is not equitable. Across socioeconomic lines, we see that children from households with incomes above $100,000 USD per year do participate in sports at twice the rate than those of children in homes making under 25,000 US a year. In terms of sustaining participation, we also see that low-income youth are 6 times more likely to drop out of sports than higher-income youth due to the costs associated with participation. Given these considerations, this study is looking at how can we use sports participation, given the benefits that have been proven in the literature, to advance health equity across the life course. So our first primary objective in order to understand better how to support youth and their families is to really understand the barriers and the facilitators of youth sports participation, and specifically the barriers related to socioeconomic status. Secondarily, we want to summarize recommendations from the literature on how to best address barriers to enable low socioeconomic youth and their families to have a more equitable chance to participate in sports and reap the same benefits that we noted earlier on. In order to operationalize these objectives, we explored 4 of the databases listed here, and we want to look at relevant published literature that discuss socioeconomic factors and youth's ability to participate in sports. With the help of the wonderful Donna Hessen at the Welsh Medical Libraries, we were able to go through the foundational literature in this field relating to sports outcomes and health outcomes, and we came up with these terms as listed in the bottom left-hand corner. by plugging these 69 articles did populate, and using this inclusion criteria listed, we were able to refine this down. And we will see on the next slide that we were able to get our sample down to a total sample size of 24 studies. So we were able to do this by filtering through this inclusion criteria, through an abstract review process, then a full text review, and we ended up with the sample size that, as we can see, the characteristics to briefly look at those was primarily looking at both female and male participants, primarily happened in community and school settings, and we do see that in terms of the country income index. Important thing to note here is we do see that it is mostly in high income, and then just one in high and upper middle, so none in low middle and low income countries. In terms of the results that this sample yielded, we see that in barriers in our primary objective, given that we were able to look at 13 total, unfortunately due to limited time, we're going to just look at the 4 that came up the most frequently. We see that financial came up in almost 80% of all studies. As we saw, registration fees was one notable barrier for children and their families to access sports, but also it extended past just registration fees as equipment fees, tournament fees, all of these surmounting to create a barrier in the financial domain. Geographically, we see that access to local organized sports, leagues, facilities, and also just transportation to and from games and practices is a significant barrier for youth and their families. In the psychosocial domain, just over half of studies noted that in terms of psychological and social barriers, we see that there's a fear of embarrassment, fear of competency, and also a lack of confidence that is reported as a barrier. And also we see an intersection with the financial realm that there's stigma and shame as well around seeking these fee waiver programs, and this also serves as a barrier. Lastly, we see that time in just under half of studies was reported, as a lack of time resources is a notable barrier, and especially for families in low socioeconomic status whose parents may hold multiple jobs, have multiple commitments. This is a significant barrier to allowing equitable sports participation amongst youth. In terms of facilitators of encouraging more youth to not only participate in sports, but sustain their participation, 62.5% of all studies did note facilitators. So we saw 9 facilitators, and the top 3 that emerged is financial enablers. We see that no proof needed waivers, which looks at any waiver really that tries to eliminate the process of having to prove salaries or providing multiple documentations, just simplifying this process really. Also looking at financial assistance programs, scholarships, reduced cost programs, those were all proven to be successful. In terms of community partnerships, we see that about 40% saw that carpool programs, volunteer coaches, and also school-based programming is a equitable way that we could also look at improving youth participation. And also in psychosocial domains, in just over a third of studies, they noted that support felt from coaches, peers, parents, and the sense of community built not only encourages youth to participate, but also sustains participation. In terms of recommendations, it was wonderful to see that all 24 of our studies, although it was not an inclusion criteria, but they all did provide a recommendation of how we could increase and sustain participation amongst youth and their families. So we see that financial did prevail as the #1 domain that we saw recommendations falling into. And this is looking at, in about 80% of studies, how could we increase funding for medical trainers? For example, if a child's injured, how do we approach rehabilitation costs, expanding financial aid and reduce cost programming, as well as how can we implement community equipment borrowing initiatives? For example, one noted a community locker library sharing equipment program that they thought would be a great idea. So similar to checking out a library book, checking out some soccer cleats, that can really help the family that cannot afford those. And looking at policy and advocacy, we see that advocating for athletic trainer for low-income areas, promoting insurance supply, for support for injury care, encouraging even trainers, training and teaching professionals. How can we also equip them to be coaches in areas that perhaps cannot have funding to bring on a coaching staff? So training existing resources and building on that capacity. And finally, in the community and partnership area, in just over 50% of studies, we see that developing these school community partnerships to lower costs, and also investing in transportation solutions for rural youth and subsidizing sport program costs through partnerships is also a viable recommendation proposed. So based on this, strengths and limitations, we did look at 12 countries on this review, which is great for the sample size. And we did list a clear inclusion and exclusion criteria And it is proposing significant equity contributions to the field, and the validity across high-income countries is great. In terms of limitations, as I noted earlier on, there was no low-middle income countries included in the sample, which highlights a huge data gap and a huge research opportunity I hope to build on in the future. In terms of the geographic and gender scope, I also hope that in the future we can look at more of low-middle income countries and countries outside of US, Canada, Australia, as that was a high overrepresentation in the sample, and also looking at female-only and non-binary inclusive studies. So the summary of what does this mean for kids? So it's important to look just beyond fee waivers do boost participation, but they're not enough on their own. We do see that adequate and effective solutions require comprehensive support. So we want to look at how these multiple barriers that they're facing beyond registration fees can be approached through layered action from policymakers and communities. And financial barriers do matter, but they're just one of several barriers that children in low resource settings are facing. So now to close, I want to look at an evidence-based call to action that is proposed based on the recommendations in the study, but also the evidence produced from the study. So we are proposing to remove these hurdles from youth through a few actionable steps. For school and community stakeholders, we want to integrate sports into educational curriculum, mobilize resources, invest in capacity building of existing school professionals, and promote fee waivers for families. We also want to see in local sports and clubs organizations install tiered pricing and flexible scheduling options to make it more accessible and flexible for families to participate in. And we also want to see at the government policy and advocacy level to increase funding, partnerships, capacity building for low socioeconomic status youth sports programming, and also enforcing policies that address systemic barriers to youth sports participation. And I just want to say a huge thank you to my thesis advisor, the wonderful Sally Safi, my content focal point, Farah Qureshi, the Population, Family, Reproductive Health Department, my cohort mates, and also the endless support of my family and friends here today. Thank you so much for listening, and I'm happy to share any references and take questions now. Thank you so much.
Great job, Flo. Thank you so much. We have time for a couple of questions. Who has a question for Flo? Feel free to come off mute, type it in the chat. I can read it. Dr. Qureshi.
I just want to say, Flo, this is amazing. I know I kind of planted a seed of an idea and Flo took it and ran with it. And so this is an incredible amount of work. And I just wanted to say congratulations and really presented well. I have about 50,000 questions, but I'll limit it to one. So you talked about gender and how there's a lack of representation in the research around around youth sports and barriers to youth sports for girls. So maybe drawing on your own experience, in addition to what you learned in your research, what do you have to kind of comment on that? Like, what do you think are the major barriers for girls? Do you think that these are common challenges? Are there different challenges or different barriers that may not have been reflected in the review you did?
Yeah, for sure. That's a great question. And I think that it's definitely something I really look forward to exploring more. I think that, especially in my own experience playing hockey, which is a very dominated male sport, even my older sisters who played hockey had a very different experience than me. And there wasn't even women's only leagues at that time. So I think that there's definitely a lot of sexism, unfortunately, in sports. And also just it is very difficult growing up in male-dominated sports and also just in the sports setting in general, because you do face a lot of people who say that sports for women is not important, no one cares about it, and it's really harmful, especially in the youth years where you're just finding your footing and your sense of self, and it is at times feels a bit discouraging. And I think that there is wonderful opportunities coming up. For example, in hockey, I know the PWHL, they just had their most recent sports league that was just introduced this past year, which is crazy that this was just happening now. But I think that the research also points to just finding ways that we can invest in research to better support girls, non-binary and trans youth as well. And I think that is a huge area of research that just really begs more attention.
Great, thank you so much.
Yeah. Dr. Hughes.
What did you say, Sally?
I said Dr. Hughes.
Oh, no wonder I didn't understand. Who's that? This is great, Flo. I'm typing a message in the chat, which basically says, this is such an important topic, and I'm surprised it's not addressed more in public health. And obviously, as a mom who had two kids heavily involved in sports, I observed some of this firsthand as much as I could see it. My question to you is, besides Go Canes, is how do you think these findings or the issues might be different in low and middle income countries, where the structure of sports is presumably, I don't know for sure, less organized and has fewer of these sort of, hierarchies of, travel teams and all of these sort of expensive accoutrements that come with sports in the US. So, I mean, I guess my question is, do you think there would be the similar impacts? And I'll just leave there and see what you have to say.
Yeah, no, that's a wonderful question. And I definitely think that that was definitely the main takeaway I took away from the limitations, is that I really wanted to think about the fact that this isn't being done in low middle income countries is shocking to me, and really just highlights in itself why we should be doing this work. But I think that especially looking at what type of initiatives we do want to implement in low middle income countries, it may be less of an importance to find equitable tournaments, but more of how do we invest in local infrastructure of getting fields, and how do we invest in equipment sharing? I think that some of those ideas and advocacy points do translate definitely to low middle income countries, but I think the biggest problem is without having the data, we really don't know how to approach an issue. And I think that's the biggest point that I want to emphasize, is that we really need to invest in the research and finding data so that we can best serve children in their own settings using information relevant to them. So
Thank you. I look forward to your work on that topic.
thank you.
Great job, Flo. Thank you so much. For the sake of time, we're going to turn to our next presenter. So next we have Gabriela Molestina. Gabriela has a Bachelor of Arts in Public Health Studies and Natural Sciences from Johns Hopkins. And Gabriela, I will turn it over to you.
Hi, everyone. Thank you for being here. My name is Gabriela Molestina, and I will be presenting a literature review on the racial and ethnic disparities in qualifying disabilities and participation in special education services and their implications for school discipline. To overview, I'll first discuss some background information in this field, the objectives and methods of my review, and go into the results and discussion. Modern special education programs in the United States are a result of policy passed in the last 50 years to provide students who have diverse learning needs with the necessary support to succeed in school. The Rehabilitation Act of 1973, which prohibited discrimination based on disability, gave rise to a policy movement protecting disabled youth in schools. Section 504 of this act specifically protects the rights of individuals with disabilities in programs funded by the Department of Education. In 1975, Congress passed the Education for All Handicapped Children Act, later renamed to the Individuals with Disabilities Education Act, or the IDEA, which granted a free appropriate public education to eligible children with disabilities. With these policies came the creation of Individualized Education Programs, or IEPs, unique documents designed for each child receiving special education that outline a plan suited to their needs. Educational experience during childhood and adolescence is a major social determinant of health, as it shapes future health outcomes, employment, and income, and is strongly linked with health behavior, morbidity, and overall well-being. This makes access to quality education during one's youth especially important. However, educational disparities persist for racial and ethnic minority students. Those with learning or behavioral disabilities face particular inequities arising from misidentification of disabilities, systemic inequities in academic institutions, and limited access to quality special education resources. Based on what is known about the relationship between race and educational outcomes, I hypothesized a variety of pathways in which race interacts with factors on community and national levels to influence disability identification, participation in special education, and disciplinary action. This is a model of a potential pathway in which provider bias and poor funding may lead to a minority student not being diagnosed with a disability they have or not qualifying for special education services when they would have benefited from it. This can lead to a lack of support for the student, which can result in behavioral challenges subject to disciplinary action. Racial and gender bias among school staff may aggravate disciplinary referrals and influence how students are classified for special education. I conducted this literature review to explore evidence for the relationships in this pathway. My objectives were to critically evaluate existing literature on the following three topics: diagnosis of minorities with learning or behavioral disabilities, minority representation in special education and whether misclassification exists. In this context, misclassification refers to under or over classification for special education. And lastly, disciplinary practices against minority students. My search strategy identified 104 studies across PubMed and EBSCOhost databases. Using Covidence as a research guide, 93 articles were screened for relevance by title and abstract, and 34 were excluded. 59 were then screened for full text review, and overall 19 studies were included in this review. My first topic looked at the diagnosis of learning and behavioral disabilities, and results showed that disparities were found by race and ethnicity. However, the reviewed literature had equivocal results. An equal number of sources found that minority students, specifically Black and Latino students, had lower rates of learning and behavioral disabilities than white students, as the number of sources that found they have higher rates of learning and behavioral disabilities. When it came to gender differences, however, results were consistent across all studies that examined this outcome. Male students were more likely than female students to be identified or diagnosed with learning and behavioral disabilities. One sizable difference is that autism spectrum disorder prevalence is 3.8 times higher among 8-year-old boys than girls. My second topic looked at the identification of students for special education programs where there appear to be more consistent trends. Results showed that minority students were less likely to be identified as eligible for special education programs than white students, regardless of whether rates of disability diagnosis for these students were higher or lower. Sources that explored the reasons for underidentification for special education commonly found that bias in assessment methods, a lack of diversity and cultural sensitivity in schools, and implicit biases among school staff were factors that led to minority students being classified for special education services far less than white students. Lastly, I looked at measures of disciplinary action, such as detention, suspension, and expulsion, and their interaction with special education status. Results were consistent across the literature in that minority students, especially Black and Latino males, were far more likely to experience an incidence of punishment in school than white or female students. Students of lower socioeconomic status also had higher rates of disciplinary action, and staff members in schools with low diversity were found to discipline minority students more than white students compared to staff in schools with high diversity. In terms of special education, students with IEPs were more likely to be suspended than students without IEPs across the literature, and this finding was consistent for all racial and ethnic groups. These results can best be summarized with the findings of one observational study conducted in a New York classroom between two students who regularly showed similar behavioral challenges. A young white girl was described by teachers to be a child with a problem or a good girl struggling with anxiety and was offered counseling. Meanwhile, the other student, a young Black boy, was described as a problem child who required special education services and was constantly disciplined with suspension. The results of this review show us that racial and ethnic inequities remain prevalent within clinical and academic institutions, regardless of strides in policy. Under-identification of minority students for special education serves as a reminder of disadvantages faced by all minorities in the U.S. inside and outside of the school system. This issue doesn't begin when a minority child starts school, but rather reflects societal biases that have been applied for generations. These biases are present across individual, community, and national levels, and ultimately become a part of the assessment, eligibility, and implementation of school services. We must also consider the consequences of misidentification in these programs. With an under-identification of eligibility for special education services, students may be left behind. When this is the case, educational needs of minority students may not be fulfilled, and they can feel unsupported. On the other hand, an over-identification in these services has downsides as well. Students incorrectly identified as requiring special education assistance when it is not needed may potentially receive an education that undermines their academic potential, and this classification, along with the identity of being a minority, may subject students to biases by school staff and unfair discipline, as results of this review have shown. As a recommendation, this review suggests that increased funding for under-resourced schools and communities is a necessity. Low-income communities are shown to have higher rates of minority families and children with disabilities than high-income communities. For many low-income parents who lack adequate healthcare access that can provide a disability diagnosis for their child, school-based identification may be depended on, which relies on local and federal funding. However, only 14% of the promised 40% of funding from the IDEA has been distributed, despite a 25% increase in students served under the IDEA in the past 2 decades. A second recommendation would be for schools to commit to diversifying their staff. This review found that white teachers were more likely to perceive minorities as having a disability and to discipline them than their non-white colleagues. Increasing the prevalence of minorities in teaching positions has the potential to reduce harmful biases against minority students in schools. This would allow for more culturally sensitive care and assessment, thus limiting misidentification of disabilities and disproportionate discipline referrals. The implications of this review are especially relevant in the context of the March 2025 executive order to begin shutting down several functions of the Department of Education, moving the responsibility of special education services to the Department of Health and Human Services. However, Texas versus Becerra, a lawsuit against the Department of Health and Human Services filed by 17 states, seeks to overturn Section 504, threatening protections for students with disabilities. Given the existing disparities in education by racial and ethnic groups found in the literature, these policy changes will impede progress in closing the gaps in disability diagnosis, special education, and disciplinary action. Because of this, it is imperative to put protective policy in place as recommended prior to mitigate the effects of harmful policy change and ensure the rights of students with disabilities to a quality education. Thank you for your attention. I would like to thank my reader, Sarah Johnson, my advisor, Kristen Mari, the Bloomberg Library informationist, Lori Rossman, for their guidance in my review, as well as all faculty in the Department of Population, Family, and Reproductive Health. Thank you. Are there any questions?
Great job. Great presentation. Thanks very much. Particularly appreciate the context at the end about current events. Who has a question for Gabriela?
It was so good, we're all awed. I want to echo something that is in the chat, which is this is also a really important topic because it's sort of I don't have to tell you, but it's sort of a central mechanism, right? A structural, impediment, structural inequity. So thank you.
Yeah, thank you.
This is David Page. I would ask, how do the racial biases during the school experience bleed into the adult issues that one has to face? Is there any nexus that exists between the two or information?
Yeah, that is a very important topic, especially in the context of my third objective, looking at disciplinary practices. A lot of my sources that specifically looked at the disciplinary practices as an outcome showed that this issue contributes to the school to prison pipeline, and that a lot of minority students, most especially Black and brown boys, view these disciplinary actions and internalize it, which turns into internalized racism. They internalize these stereotypes, and they are therefore after school more likely to not graduate on time, become what is known as disconnected youth, meaning after 18 years old, they are not employed or going to receive any form of education, and of course more likely to get into federal troubles with crime. So it definitely is something that becomes internal from being subjected to it from middle and high school, that they carry with these, unfortunately, into adulthood.
Thank you for a great answer and a great presentation. Thank you.
Thank you.
This is, I'll speak up again. As you were speaking, Gabby, that was a great answer. I was thinking about, we often think about life course impacts on health, but this is actually a constellation of forces that sort of affects the future life trajectory, which can then affect health. Not that there aren't health effects that begin in childhood and adolescence, but you articulated it really well that this is sort of a centerpiece there.
Right, thank you.
Great job again, Gabriela. Thanks so much. We'll turn to our next presentation. Sachi Takeuchi comes to us with a Bachelor of Nursing and a Master's of Nursing Science from Osaka University. So Sachi, I'll turn it over to you.
Hello everyone, I'm Sachi. Today I will be presenting findings from a scoping review and critical appraisal of literature of case management within the maternal, infant, and early childhood home visiting MICV context. Before I start, I would like to sincerely thank my first essay reader, Alison West, and the wonderful project team, Kiara, Diana, Constance, Jen, Patricia, and Jessica, who are also joining us today. MICV supports evidence-based home visiting across 56 states and territories. However, despite significant federal investment, average effect sizes remain modest, around 0.10. Case management is a core pillar of many MICV models. The Jackie Walorski Maternal and Child Home Visiting Reauthorization Act of 2022 allocated funds for workforce support, retention, and case management. However, there is a clear research gap. No review has examined case management within this context. To address this gap, and as a part of a larger project, we conducted a scoping review to examine case management within MICV-funded evidence-based home visiting programs. The specific objectives were to describe the characteristics of case management, summarize the outcomes reported in the studies, identify potential active ingredients, and assess the risk of bias. This scoping review followed the 6-step framework. The inclusion criteria were evaluated case management within MICV-funded or eligible evidence-based home visiting programs for expectant families or families with children aged 0 to 5, used experimental or quasi-experimental design. Also optional in scoping reviews, we assessed risk of bias to enhance the rigor and interpretability of the findings and contextualize evidence strengths. Given the focus on experimental and quasi-experimental studies, we deemed it appropriate to assess internal validity using a structured risk of bias approach. We used the ROB2 tool for RCTs to assess bias across 5 domains: randomization, deviations, missing data, outcome measurement, and result selection. Each domain and overall rating range from low to high risk. For quasi-experimental studies, we use the Robbins-1 tool, evaluating bias in confounding, selection, deviations, missing data, and outcome measurement. Each domain and overall rating range from low to critical risk. 14 studies were included in the final review. Study designs were 2 experimental and 12 quasi-experimental designs. I will now walk through the results aligned with the objectives, starting with the describe the characteristics of case management. Regarding service settings, 6 studies focused solely on home visiting, while the remaining 8 studies involved collaboration with other services, including local clinics, Head Start, early intervention partnership, and community health work. Therefore, no study collaborated with central intake, which was the first surprising fact here. Next, regarding the financing of case management, the second surprising fact here is that only 3 studies describe the funding for case management beyond the MICV base model. A wide range of roles provided case management, including home visitors, nurses, social workers, community health workers, and more. Provider composition, 7 studies used a single provider type, and another 7 studies involved multiple provider types. Various MICV models were used as the base models for the case management interventions. Additionally, various implementation system inputs for case management and functions and activities were used. summarized the outcomes reported in the studies. Outcomes from 14 studies were mapped to 8 domains used by Home VEE, a federal initiative that reviews evidence for home visiting programs. Linkages and referrals was the most reported outcome, followed by maternal health and child health, family economic self-sufficiency, and positive parenting. No outcomes were reported for reductions in juvenile delinquency, family violence or crime, child development and school readiness, or reductions in child maltreatment. Identify potential active ingredients. From a semantic analysis of 3 studies showing improvements in both referrals and family outcomes, 2 key themes emerged. First, relationship-centered approaches grounded in family needs. Second, routine case review systems. Assess the risk of bias. We identified 2 RCTs by Beaver and Jack, examined the effectiveness of additional nurse-led case management interventions integrated into the base MIC-B model. Both RCTs had a high overall risk of bias. Key concerns included baseline imbalances not adjusted, self-reported outcomes without assessor blinding, and post-randomization exclusions violating intention to treat principles. Next, 12 COGI experimental studies. 10 were rated as having serious or critical risk due to issues like confounding unadjusted, baseline imbalances uncorrected, missing data not addressed, and selective reporting. 2 studies were rated as lower risk using multiple strategies to reduce bias. For example, Rafford's study on collocated MIC-B staff implemented case management interventions used comprehensive propensity score adjustment, difference in differences design, kernel weighting, linked administrative data, full reporting, and sensitivity analysis. And there is another lower risk study, Roman's study. Roman's study on system-level case management interventions used a similar approach, but faced residual community-level confounding remained after sensitivity analysis due to limited baseline data, which resulted in low moderate risk of bias. There is limited research, so there is a need for more research. This slide highlights the importance of precision home visiting research to standardize the 2 potential active ingredients as the best practices in real-world settings. The 2 potential active ingredients we identified in this review were part of base models. So my thought here is that the context of experimental studies may have contributed to the standardization of intervention frequency, helping to reduce pervasive variation across interventions and potentially leading to more favorable outcomes. Also importantly, the 2 potential active ingredients are supported by 2 lower risk of bias COGI experimental studies, and 1 high risk of bias RCT also supports these ingredients, but the magnitude of the risk is large, and its bias direction varies across domains, making the results unpredictable. As such, it is not supported by a reliable RCT at all. Therefore, precision home visiting research is needed to determine the optimal frequency of the two key active ingredients and assess their effectiveness with the goal to standardize the best practices in real-world settings. This slide highlights the potential to strengthen the overall MICB program beyond case management. The two potential active ingredients for case management within MICB context align with key success factors of the overall MICB program identified in a prior multiple case study and the integrated review. Also, the two potential active ingredients for case management correspond to the two central components of donor variance healthcare quality framework. Therefore, the two potential active ingredients for case management within MICB context may have a potential to strengthen the overall MICB program beyond the case management and its quality. Finally, current evidence is limited by a lack of economic evaluation and methodological weakness, hindering a full assessment of cost effectiveness and the intervention's impact. Thank you. Any questions?
Thanks so much, Sachi. Great work. I think you can go ahead and stop sharing your screen if you'd like, and we'll have time for a couple of questions. Sachi, I'm curious to hear more about those active ingredients you identified. Could you just maybe expand on exactly what those mean a bit more?
Yeah, I found two active ingredients which were relationship-centered care and also case review systems. Those are the fundamental factors. It's originally within the MICB context. So yeah.
May I jump in? Thank you for the presentation. On the domains that you looked at, you had 8 domains, and you had child maltreatment, juvenile delinquency, and of that particular problematic orientation. Yet there were no visits. Was that deliberately because the child visits excluded that, or it would seem strange in a high-risk population that wouldn't come up? It was, I think, on the domains that you were looking at.
Sorry, could you repeat your question? I'm sorry.
On your slide.
I'm sorry. Could you repeat your question?
Dr. Page, could you maybe just ask the question one more time?
Yes, of course. The absence of child maltreatment and juvenile delinquency, and perhaps there was another one, were 0 with respect to the child visits. And I was curious as to why the absence there. Perhaps the child visits were precluded to those homes or referred on because of those problems.
Yeah. Reductions in child treatment didn't exist within the outcomes.
I think my notes said outcomes of the 14 studies and federal review. It's not a question, critical question. I was just curious.
Yes, I agree with your curiosity. Yes, I want the literature. Another scoping review on linked data within MICB context doesn't have outcomes on or smaller number of outcomes in reductions in maltreatment as well. So my results, my findings is aligning with another systematic review on linked data within the MICB context. So this is the issue. Yeah, here is the issue. So
Yes.
yeah, I'm curious about why they don't have the outcome in reductions in child maltreatment as well.
Thank you.
Probably my guess is that the data, we have smaller access to the data in child maltreatment right now. So the study is small. So we needed to investigate in the future study, I think. Yeah.
Thank you.
Yeah. Thank you.
All right, great job, Sachi. Thanks again. We'll now turn to our final presentation. Annaliese Collins comes to Hopkins with a Bachelor of Arts in Public Health from Muhlenberg College. And Annaliese, I will pass it over to you.
There we go.
It looks good.
Yeah, I think the universe needed to give me a little bit of a struggle before I started this. Okay. Hello, everyone. My name is Annaliese Collins, and I'm presenting this master's essay presentation for the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. The topic is Approaching the Reproductive and Sexual Health Needs of Women Who Use Drugs Through a Harm Reduction Lens, Baltimore and Beyond. My faculty reader is Danielle Friedman-Nedstadt. Reproductive and sexual health care is globally recognized as a human right and is vital for an individual's overall health, well-being, autonomy, and relationships. However, in the United States, systemic barriers and contextual factors lead to unequal access to care, particularly for those with intersecting marginalized identities. This presentation focuses on women who use drugs. The core issue I focused on is that women who use drugs in the United States and Baltimore City frequently have unmet reproductive and sexual health care needs. This is primarily due to structural barriers and stigma, which result in limited access, restricted autonomy, and worsened health disparities. The goal of this policy analysis is to understand these disparities, identify their causes, and explore how a harm reduction lens can inform effective approaches to care. When we speak of reproductive and sexual health, the World Health Organization defines it as having a complete physical, mental, and social well-being in all matters relating to one's reproductive system and its functions. Services cover a range of areas, including access to effective contraception, maternal and perinatal care, fertility and infertility treatment and counseling, sexually transmitted infection prevention and treatment, healthy relationship education, and prevention and protection against sexual and gender-based violence. Next slide. Meeting these needs is crucial because it empowers individuals to make decisions about their bodies, relationships, and futures. Conversely, the consequences of unmet needs can be severe, including unintended pregnancies, STIs, including HIV, maternal mortality, and exposure to sexual and gender-based violence. Next slide. Looking at the scale of drug use to further understand the magnitude of the disparities faced by women who use drugs, nationally, 70.3 million individuals aged 12 and older reported using illicit substances in the past year in 2022. Closer to home, Baltimore City experienced 1,043 drug and alcohol-related deaths in 2023. It's important to note that these numbers may be underestimated and don't reflect the true magnitude of drug use in the United States and Baltimore. Next slide. Turning to reproductive health disparities, women who use drugs face significantly higher rates of unintended pregnancy. One study found nearly 9 out of 10 pregnancies were unintended among pregnant women who use drugs, compared to about 41.6% in the general population of pregnant women. Women who use drugs also show lower rates of consistent and effective contraceptive use, which can increase the risk of unintended pregnancy. The impact of these disparities is clear, especially among specific populations of women who use drugs, such as women who sell or trade sex and use drugs, and pregnant women who use drugs. Drug overdose is a leading cause of maternal mortality among pregnant women who use drugs nationally. Tragically, it was the leading cause of pregnancy-associated death in Maryland in 2020 for the 8th consecutive year. Furthermore, people who use drugs, particularly women who inject drugs and women who exchange sex, are at a heightened risk for STIs and HIV. Women who inject drugs accounted for 3% of new HIV diagnoses nationally in 2022, and women who exchange sex experienced an HIV prevalence 8.8 times higher than women in the general population. Next slide. Understanding the drivers is key. disparities result from a combination of structural, social, and individual factors. A major contributor is stigma, which is pervasive and exists at structural, societal, and internalized levels. Stigma can result in discrimination and prejudice from others, including from healthcare professionals. It can also lead to low self-esteem, low self-efficacy, and create perceived and actual barriers to care, limiting autonomy and trust. This is compounded for those with intersecting identities, such as women who sell or trade sex or pregnant women. Beyond stigma, structural barriers like legislation and policy inadvertently deepen disparities. The criminalization of drug use, sex work, and drug use during pregnancy leads to fear of legal consequences, deterring women who use drugs from seeking care. Punitive laws regarding drug use in pregnancy are associated with a 45% increase in maternal overdose, and the criminalization of sex work is linked to increased risks of HIV and STIs, violence, and inconsistent condom use. Historically, women who use drugs have also faced structural barriers such as forced or incentivized sterilization. These many barriers can also enable discrimination and stigma from providers. Currently, few policies are apparent in the United States that address the specific reproductive and sexual health needs of women who use drugs. Next slide. Women who use drugs often face significant structural vulnerabilities such as houselessness, food insecurity, financial insecurity, and violence. These vulnerabilities interact synergistically with substance use, intensifying health disparities. For many, obtaining basic needs may take priority over seeking reproductive and sexual health care. These vulnerabilities are associated with poor health outcomes like chronic disease and decreased life expectancy. These structural barriers and vulnerabilities contribute to low utilization of preventative health care among women who use drugs. Additionally, drug use itself can facilitate high-risk sexual behaviors due to its psychoactive effects. Next slide. My thesis states that women who use drugs in the US and Baltimore City face significant barriers to reproductive and sexual health care due to structural stigma and systemic inequities, limiting autonomy and exacerbating disparities. To tackle these complex issues, my thesis proposes integrating non-judgmental, trauma-informed care in all services targeting women who use drugs through provider education from a harm reduction perspective. It stresses the need to prioritize community input to build trust and meet actual needs, and it recommends co-locating services to increase access and continuity of care. Next slide. My previous recommendations for care providers are structured through a harm reduction approach. The harm reduction framework by the Substance Abuse and Mental Health Services Administration is an operationalized, evidence-based approach using community-driven strategies to empower people who use drugs. It emphasizes community engagement, recognizing the inherent value of people, equity, accessible support, and valuing any positive change as defined by the individual. Next slide. The first recommendation is co-locating services. This ensures comprehensive care in a single setting, reducing barriers like transportation and fragmented care. It also improves patient-provider relationships, minimizes stigma avoidance, and enhances continuity of care. This approach is supported by the harm reduction framework and has proven successful in pilot programs, particularly within syringe service programs, mobile clinics, and primary care. Syringe service programs are community-based public health programs that provide a variety of services, most notably sterile syringes and syringe disposal. In Maryland, there are 27 SSPs, with 8 authorized in Baltimore City, some of which are already co-locating reproductive and sexual healthcare services. Next slide. The second critical recommendation is providing non-judgmental, trauma-informed care supported by provider education. Women who use drugs experience high levels of trauma, and this approach creates a safe, supportive environment free from stigma and re-traumatization by acknowledging trauma's impact. Provider education is essential to reduce stigma, correct misinformation, and improve the quality of care, including behavioral competencies such as soft skills and provider attitudes. Next slide. Finally, prioritizing community input is vital. This ensures services truly reflect the needs of women who use drugs, fostering trust and empowerment. Community engagement is an essential pillar of harm reduction, highlighting leadership by people with lived experiences. In the research I have done, community input has been shown to improve health outcomes for marginalized populations, and it requires intentional partnerships between organizations and the community they serve. Next slide. A current example incorporating these principles is Spark Center for Women. Spark was founded in 2017 by Johns Hopkins as a pilot program to increase community access to judgment-free, low-barrier, free harm reduction services tailored to the specific needs of women, non-binary folk, and people who don't identify as men who use drugs and sell sex in Southwest Baltimore. The center is a syringe service program and provides co-located reproductive and sexual health care services, case management, and safer drug use supplies, among other services, through a trauma-informed harm reduction approach that centers the voices of the community it serves. On average, Spark has about 1,200 encounters each month through their drop-by center, medical and case management appointments, mobile outreach services, and contracted buprenorphine and Suboxone treatment services. The Spark Center is a pertinent example of a program that utilizes a multifaceted, low-barrier approach informed by harm reduction to address the reproductive and sexual healthcare needs of women who use drugs and women who engage in sex work. This program provides key insights into how the recommendations of co-located services, utilizing trauma-informed and non-judgmental care, and incorporating community engagement can be effectively and successfully implemented. Next slide. In conclusion, addressing these unmet needs requires moving beyond traditional approaches, especially in the current hostile environment for reproductive and sexual health created by the current Trump administration. The call to action is clear. Implementing co-located services, non-judgmental, trauma-informed care supported by provider education, and prioritizing community input through a harm reduction lens is crucial. This is essential to improving reproductive and sexual health outcomes and promoting health equity for women who use drugs in Baltimore and beyond. Thank you. Next slide. Any questions?
Great job. Great job working through the minor road bump there. And thanks everybody for bearing with us. Annie, would you like to ask a question?
Hi, Annaliese. Thanks so much for your presentation. I think that harm reduction has been sort of well established in a behavioral health context. And I was wondering if you could speak to what harm reduction looks like in the context of reproductive health care.
Yeah, so I currently work at Spark Women's Center, so that was kind of a shameless plug. But working there, we have a lot of people that do engage in sex work, and I think that probably is one of the most significant ways that reproductive and sexual health care and harm reduction kind of go together, because the individuals that we interact with are engaging in a high-risk sexual behavior. And this is a behavior that a lot of them may have to engage in order to, find drugs, get shelter, get money, things like that. So giving them the resources that they need, like free condoms, teaching them how to actually put on a condom, giving them monthly STI tests, putting them on PrEP, things like that, is how harm reduction can be used in reproductive and sexual health care, at least in the field that I'm interested in.
Maybe I'll ask one more. And just in terms of harm reduction, I think that those strategies, while there may be scientific evidence demonstrating effectiveness, they can still be controversial. Do you have any thoughts about convincing, the broader population that your proposal would be effective and needed?
Mm-hmm. So one of the analogies that I give about harm reduction is that because a lot of people think that harm reduction, when people engage with it, you're encouraging people to engage in certain behaviors that are harmful. So I always give the example that if a condom shop opened up on the corner, do you think people would be like, well, now I'm going to engage in sex because of this condom shop? No, people who are engaging in sex are going to use the condom shop, or someone who wants to engage in sex is going to use the condom shop. But it's not going to be that facilitator or that motivator for a person, just because there's now easier access to condoms, that they're going to change their mind and suddenly start engaging in sex. So I give the analogy that we are providing people with the resources that they need to make sure that they can make informed decisions, while providing support and still allowing people to acknowledge the fact their humanity, because I think that's a very big part, is people that engage in potentially harmful behaviors are often regarded as someone that's less than. There's a lot of stigma associated with it. So just reminding people that everyone deserves health and everyone deserves respect is something that I think goes pretty far.
Yeah, thanks so much. I think that that is a great note to end on. So thanks so much for your contributions. Thanks to all of our presenters, and again to everybody here for supporting our students through the master's essay process and through the program in general. We're so proud of all of you. Huge congratulations. Hope to see many of you at the graduation party next week. And thanks again for attending. Have a great rest of your day.